lecture is after surgery is when to give radiosurgery, and by Professor Dwarkanath Srinibas from NIMHANS, National Institute for Mental Health and Neuroscience, Bangalore, India.
So can you see my slides and
Yes.
Thank you. Thank you, sir. Thank you for the invitation. We are at a changing paradigm of management in which radiosurgery is gradually taking over the functions what whole brain radiotherapy used to do 20, 30 years back. And this is primarily, and the epidemiology of brain mets, which has already been mentioned, is that we are going to see more and more brain metastasis for treatment for the simple reason that because of the advances in treatment for the primary malignancy, patients are living longer and there is an increased life expectancy and improved survival. So like the radiology was already mentioned, so I'll not go through it. Again, you have basically two types. One is the well delineated ones and one is the leptomeningeal origin types, which causes a diffuse coating and which are basically not suited for radiosurgery. So the question is, how do you manage brain metastasis? Would you like to treat the patient aggressively? Would you treat based on the number of metastases? Would you be treating on the basis of the pathology? Would you treat the systemic profile? Would you include the immunotherapy into the treatment paradigms? So there are many factors which you need to take into consideration before you start your treatment. And the question is, and this was a scale which was developed in the 1960s, which gave basically a graded prognostic assessment based on these four main features of age, KPS, number of CNS metastases, and extracranial metastases. And then the score was given, and the higher the score, better the survival. The question is whether the different primaries have a different survival rate. If you see over here, regardless of the primary, the average survival is more or less the same, slightly higher, slightly lower. Again, in breast cancer metastasis, the genetic also plays an important role in the prognostication. So what treatment modalities do we have? One, of course, we have the steroids, which are basically palliative along with anti-seizure medications. Some centers use external beam radiotherapy as palliative, and the median survival is less than 15 weeks. The aggressive treatment is basically surgery or radiosurgery along with whole brain radiotherapy and chemotherapy and immunotherapy. So let us first discuss what are the controversies in management. One is, of course, the solitary brain metastasis, where the controversy is whether to use surgery or SRS and whether to give WBRT or not. Then group of 1 to 4 metastases, and the third group is greater than 4 to 5 metastases, where the primary discussion is between SRS versus whole brain radiotherapy. Like the previous speaker mentioned, the landmark study by Patchell, of course, proved that surgery, complete excision followed by whole brain radiotherapy definitely improves the survival significantly. And the current recommendations for surgery include predominantly solitary lesions more than 3 centimeters, providing diagnosis if none exist, gives you tissue for molecular subtyping, relieves symptoms due to mass effect, gives you complete local resection, avoids new deficits, and then helps you wean off steroids faster. What are the differences between surgery versus gamma knife or radiosurgery is that the SRS is basically, it helps you treat small eloquent lesions. It helps you treat multiple lesions in small durations. It's minimally invasive compared to surgery. And there's a thing of potentially avoiding whole brain radiotherapy. The question is whether you will treat a single metastasis or whether you'll treat multiple metastases in the same way. Whether you treat small metastasis or more than 2 centimeter metastasis in the same way. How much radiation would you give? Would you fractionate it or not? And whether the treatment for radio-resistant and radiosensitive metastasis varies. Of course, for the single metastasis, we have already discussed surgery if there is mass effect and radiosurgery if there's no mass effect. So what do you do if you have 1 to 5 metastasis? And if you see historically, whole brain radiotherapy was the treatment of choice. while SRS is coming up newly and it delivers high dose radiation only to the visible brain metastasis. But the main disadvantage of whole brain radiotherapy, which has been the significant neurocognitive side effects. And so this raised a question as to whether surgery should be offered. Is whole brain radiotherapy actually necessary? Does it offer any benefit vis-a-vis SRS? Would you use radioprotective techniques? Can you use SRS alone as a treatment modality? And is there any difference in both the recurrence-free survival as the overall survival in SRS versus W brain therapy? So the first question, the question is, should radiotherapy be actually offered to patients with metastasis? And there have been a sort of general consensus that if your KPS is very poor, and if you have no systemic therapy options, then probably it's better not to offer radiotherapy at all. But again, in this subgroup, there have been improved survival associated with whole brain radiotherapy for subgroups with better prognosis, such as greater than, say, 60 years old patients. This again is because of the side effects of whole brain radiotherapy, of which neurocognitive decline is the most significant, but it also has other side effects such as somnolence, alopecia, fatigue, skin erythema, otitis, radiation necrosis, and leukoencephalopathy. And this neurocognitive decline has been found in almost 11 to 15% of patients who underwent whole brain radiotherapy. They generally occur 3 to 4 months after treatment and has been the destruction of the hippocampal cells. To prevent this, there have been studies and in which memantine has been used to slow down the cognitive function. And also newer techniques such as hippocampal sparing has been associated with less severe impairment on some neurocognitive tests. And the RTOG 0933, which is evaluating neurocognitive performance, the results are pending. So generally, the whole brain radiotherapy is falling out of favor in 1 to 4 metastasis. And now more or less it's been limited to patients who have diffuse leptomeningeal disease or too numerous to count metastasis or very poor KPS where it's used as a palliative treatment. And if you're giving whole brain radiotherapy, it's important to consider to use memantine, which is an NMDR antagonist, and also consider hippocampal sparing radiation as shown in this diagram. With a less than 5% metastasis in the hippocampal area, but still you need to use a hippocampal sparing radiation. So the greatest advantage of radiosurgery is that, of course, apart from it being non-invasive outpatient procedure, there's no requirement for local anesthesia, is the fact that you get a very good conformality index, especially with gamma knife. And if you see this clearly, the red line is this is a gamma knife plan. The red line is the tumor outline, the yellow line is the 50% isodose line, and the green line is the 20% isodose line. So if we were giving 20 grays over here to the margins, this is around the 10 gray line. So you can see that the rapid fall off of the dosage from the tumor into the surrounding brain. So the conformality is very good and you can give a greater dose of radiation to a smaller area. And metastasis is very ideally suited because if you see, unlike a glioblastoma, which has infiltrates into the white matter and it's very difficult to target and frequently reach larger sizes, brain metastasis has quite a sharp demarcation from the surrounding tissue. And even if you go for a few millimeters, you still get a 45% dose of the central dosing to the radiosurgery periphery, which still is good enough for many of these metastases. So we use the gamma knife in our center, and with the new icon and the perfection, we can do both a stereotactic frame fixed SRS, or we can use the mask based, which is also available on the LINAC based machines. So both of them, we do the volumetric MRI on the 3 Tesla or the 1.5 Tesla as mentioned by Professor Mukherjee, then do a CT, merge the images and treat metastasis. So coming back to the role in 1 to 4 metastasis is that the Andrews et al. Showed that SRS boost to whole brain radiotherapy does not increase overall survival. But SRS added to whole brain radiotherapy improves local control. And there have been multiple class 3 studies which says that it is safe and effective to use focal radiotherapy to improve local control. And Chang et al. Said that if you withhold WBRT in favor of radiosurgery alone, you have improved neurocognition, survival is more or less the same, but has decreased on local and distant control. IOMA, where they compared SRS versus WBRT plus SRS, uh, there was no difference in the two groups in terms of OS, but the local and distant failures as well as salvage therapy was significantly lesser in the WBRT group. While one of the studies was stopped due to increased neurocognitive whole brain radiotherapy. So one of the main concerns raised in all these studies was the fact that there are going to be local distant failures that is the occurrence of metastasis in other sites in the brain if you do not give whole brain radiotherapy. But if you give whole brain radiotherapy, there's going to be an increased neurocognitive outcomes, worse neurocognitive outcomes. So what are the recommendations by Astro is that SRS is definitely an option when the overall volume of lesion is clinically determined to be small. It can be added in multiple metastasis only if you have leptomeningeal enhancements and to improve local and distant control. But more or less in 1 to 4 metastasis, what has happened is that there has been a shift to use SRS alone, defer the use of whole brain radiotherapy as a salvage regimen, and do serial scans. And if there are going to be fresh lesions elsewhere in the brain, you again treat them with SRS. So you increase the surveillance, and any new and emerging lesions can be treated with repeat dose of gamma knife or SRS. So what this does is it takes away the problem of recurrence because you are doing frequent monitoring with serial MRIs, and also decreases the neurocognitive effects, which is a significant problem with whole brain radiotherapy. So what happens if you have more than 5 metastases? There have been multiple studies again in which SRS had, which has shown that SRS had greater mean survival time, higher freedom from neurological death, and higher quantitative survival. SRS can effectively treat 5 or more metastases at any time. And SRS alone without WBRT provides excellent survival in patients with 1 to 10 brain metastases. So basically what all these studies have shown is that the results of 1 to 4 metastases have more or less been replicated with 5 to 10 metastases. But even though we have had good quality studies in the 1 to 4 metastasis group, the quality studies are not still available in the greater than 5 metastasis group. There's one large study by Yamamoto et al. From Japan in 1194 patients. They showed that between single metastasis and multiple metastasis, there was a significant survival difference, but the number of metastases if greater than 1 did not affect survival. Non-inferiority of stereotactic radiosurgery without WBRT with 5 to 10 metastases as compared to those with 2 to 4 tumors. So it basically means that even though it is not a good control, there is non-inferiority of stereotactic radiosurgery. And considering the neurocognitive effects of WBRT, SRS provides equivalent local control without changing overall survival with respect to WBRT. And the EORTC study also showed that like 1 to 4 metastasis, while WBRT reduces intracranial lapses, it does not improve the duration of functional independence or survival. So basically what this whole thing means is that what is happening in 1 to 4 metastasis, the same thing is happening with more than 5 metastases. So what are the current status for greater than 5 metastases as per the Astro recommendation is that evidence is limited to retrospective studies, so therefore it's not a good quality evidence. But in selected patient population, there is no difference in overall survival if you compare SRS alone with WBRT with SRS for multiple metastases. So a consensus in a poll of majority physicians attending radiosurgery meetings, they consider it reasonable to treat 5 or more metastases with SRS despite lack of RCTs due to the significant neurocognitive effects associated with WBRT. And also because SRS, the ease of delivery and the improved systems means that more facilities are available and SRS can be used frequently, and they make up for the lack of for the increased relapses in other sites by doing frequent imaging and retreating them if necessary. The other question is how many metastases is too much? Whether you treat with 20 metastases, 40 metastases, 35 metastases, 20 metastases, we don't know. So because the cumulative volume of metastasis is more important than the absolute number of metastases. So the number of metastases has been taken away, and the cumulative volume is more used to decide whether the patient can go in for SRS or for whole brain radiotherapy. For example, this patient with multiple metastases, if you can see, she's almost had 16 metastases, was treated. And if you can see the number of metastases, incidentally, the patient also has a cavernoma in the right basal ganglia. So this is the cavernoma here, but you can see the number of metastases over there. And all of them can be treated because the cumulative tumor dose is within limits. And this is the post after 3 months. You can see there's been a decrease in the metastasis. So there have been studies on this as to whether new metastasis after gamma knife surgery, what happens to them. So in this, it says that while new metastasis did develop in 50% of the patients, additional gamma knife was extremely effective in controlling disease, and fewer than 20% actually required whole brain radiotherapy, and a majority died due to the progression of neurological disorders. So coming to the third point, delivering radiosurgery. Would you use a gamma knife or a LINAC-based system? I think multiple centers around the world use either of them. There's been no significant difference between the outcomes. But the gamma knife system does have a lesser error of 0.48 millimeters compared to around 1.5 millimeters of a cyber knife system. The conformability index is better, 1.17 versus 2.7 to 2. And the other important thing is because you're going to treat a large volume in multiple metastases, the extracranial dose is significantly less with gamma knife compared to the cyber knife. The other question which we've had to answer is, does single dose SRS have the same effect as 3 to 5 fractions? This is because what happens is as the volume of the brain metastases increase, you will have to get the dose down. So, and what happens is if you get the dose down to 15 grays or 18 grays, the control loads drop from 85% to almost 49 to 45%. So can you give a dose equivalent of around 20 to 22 grays by fractionating it in 3 to 5 fractions and then delivering it? So this is something we don't know, but many centers, including ours, where if the total volume exceeds around 12 grays, 12 cc, we tend to fractionate it and give it over 3 fractions and give a biological equivalent dose of 20 to 22 grays for metastasis. So most centers use at least 18 grays, we use around 20 grays. And the reported local control rates in multiple series have varied from 70 to 95% in various types of malignancies, regardless of whether they have been traditionally considered to be radio sensitive or radio resistance. And this again shows the same graph in which higher dose decreases the local failure. This is what I mentioned. What happens if there is larger brain metastasis? One is, of course, fractionating the dose. And the second thing is to give 2 doses spread over 3 to 4 weeks. So this was a study by Angelov et al., in which they treated metastasis greater than 2 centimeters in diameter. And what they did was, in the first stage, they gave 15 grays, did an MRI after average of around 30 days, and then marked the tumor and gave another 15 grays. And they found that between stage 1 and stage 2, the tumor had actually shrunk by around 30%. So they were able to treat smaller volumes at the second stage, and they had an excellent overall local control of around 88%. So these are similar studies. So these are the various strategies available, whether you can do it in a single session, you stage it over weeks, or stage it over fractionated over 3 to 5 days. We still don't know the answer, but this was a paper published by Angelov in which they showed that this was the metastasis treated stage 1, it had shrunk in stage 2, and over a period of time it had significantly decreased in size. So coming to the role of SRS with immunotherapy, of course, immunotherapy has been used in multiple patients. I will not go into detail because mine is about radiotherapy, but the inhibitors, immunotherapy drugs have been used in melanoma, HER2 positive cancers, and NS non-small cell lung carcinomas, and they act basically because of the abscopal effect, where the systemic immune response is activated and the primary tumor gets irradiated and releases the tumor antigen in the blood. So it's worthwhile using immunotherapy if the tumors happen to be responsive to them. So finally, I'll come to the recommendations, which is a summary. Uh, the first recommendation, it should not be offered to patients with asymptomatic brain metastasis who have KPS less than 50 or a KPS 70 but no systemic therapy options. SRS alone should be offered to patients with 1 to 4 unresected metastases, excluding small cell carcinomas. It should be offered to patients after surgery also to increase local control. For greater than 4 metastases, SRS, WBT are a combination of all reasonable options. There's no hard data to differentiate between them as which is good to which is bad. But of course, you have to remember that WBRT has a higher incidence of neurocognitive decline, though that has come down with hippocampal sparing techniques. Again, if you're using whole brain radiotherapy, you should use memantine and hippocampal avoidance, especially if the expected survival is long. And there is no evidence to support the use of radiation sensitizing agents in these patients. So I would like to conclude by saying that models do exist to understand median life expectancy for metastasis. It's not a bleak future. The role of steroids should be constantly evaluated, and the faster you taper off steroids, the better it's for the patients. Surgery has a role in large symptomatic brain metastasis. Radiation is required either as a pre or the post, as mentioned by my previous speaker. Metastasis is a very typically ideal target for gamma knife. Whole brain radiotherapy increases cognitive decline and should be used in selective circumstances, which is constantly coming down, and you should use memantine and hippocampal sparing techniques. SRS dosing is based on the tumor size and the volume. You can consider multiple stage SRS for tumors which fit into those criteria, and you can use both frame and mask options for these metastases. Thank you.
Thank you, Dr. Dwarkanath, for giving lucid and clarity on how to go about brain metastasis. Depending on, it's not the numbers, but the volume also is important, and the follow-up with the proper investigation also will decide what kind of treatment to be done. There are some questions in the chat box you have to reply as we are short of